Our speaker today is Dr. Jeffrey Rakofsky. He is a psychiatrist, professor, and distinguished physician in the Department of Psychiatry and Behavioral Sciences here at Emory University. He runs the, he's the director of the medical student education, working with the entire third-year class of medical students, and he directs the bipolar disorders clinic that evaluates people throughout the Southeast. Dr. Rakofsky, he has a special place in my heart because he was one of my trainees as a medical student, and he won't tell you this, but he's a musician. He started out as a musician. In any event, Dr. Rakofsky, he is going to talk to us about things that lead to involuntary, means you didn't go willingly, hospitalizations caused by psychiatric disorders. Dr. Rakofsky.
Hello, thank you so much. It's great to be here, and thank you for that kind introduction. I'm going to go ahead and pull up my slides. Here we go. And hopefully there they are. Are they in presentation? Wait, hold on. All right, they in presentation mode?
Yes, sir. Looks good.
All right, then let's get started. So we're going to talk about involuntary psychiatric hospitalization. The learning objectives include understanding the purpose of involuntary psychiatric hospitalizations. Why do we do this? Like, what's the point of it? Objectives are to also name the illnesses and the behaviors associated with these involuntary psychiatric hospitalizations, to list the sequence of the different legal holds that are used during this process, and then finally to list the ways that a person can be held involuntarily in a psychiatric hospital. So let's start. So the purpose of these hospitalizations, this is not a fun part of our job. We don't like this part. You know, a lot of us believe in patient autonomy, letting people live their lives. So this is not something we love, but there's a purpose behind it. There's a reason why this is needed sometimes. So first is to keep a person with dangerous psychiatric symptoms safe from themselves, so that they don't do anything to harm themselves or to put their lives at risk. Another reason is, excuse me, to keep the public safe from a person with dangerous psychiatric symptoms. Sometimes there are certain symptoms that could pose harm to the general public. But also, and most importantly, to provide treatment for these individuals who have these particular symptoms. So when they're in the hospital, it's not just about keeping them safe, but it's also about initiating treatment to help make those symptoms go away so that they're no longer safe and they can go back to their lives and back to their families once the hospitalization is complete. Let's talk about what some of those dangerous symptoms are, because not all psychiatric symptoms are dangerous, but there are a couple that are certainly noteworthy. One is suicidal ideation. So this is when a person has a wish to be dead. It's a scary thought. But some of our patients have these symptoms. And just because a patient has these kinds of wishes or thoughts doesn't mean they have to be in the hospital. But when it gets to the point where they feel like they're going to act on those thoughts or they can't control the thoughts, that's where hospitalization becomes really helpful, because then they have people to watch them, to talk to them about what they're going through, whatever illness is leading to this particular symptom. So this is something that we really want to keep an eye on. Homicidal ideation, wanting to harm somebody else. That's also a symptom that sometimes develops in people with psychiatric illness. Not always. I want to make it very clear. There are plenty of psychiatric illnesses where this is not an issue, but there are some illnesses where sometimes this can develop. And the person sometimes will tell us, and that's great. And if they can tell us, and if they're able to just have the thought, but know they're not going to act on it, then potentially it's something that we can treat outside of the hospital. But again, if they feel like they can't control it and they're going to act on it, that's where being in a hospital setting is important, once again, because they can be monitored, and also so that we can initiate the treatment that will help whatever is causing that particular symptom. And then poor judgment. So poor judgment can then lead to decisions with a high risk for a lethal outcome for either the person or others around them. So what's an example of poor judgment? How about driving 120 miles an hour? How about climbing up a building in the middle of the night? I'm just trying to think of things that patients have told me over the years. These are things that can lead to harm, not with the intention of leading to harm, but can inadvertently lead to harm. And so, so in those situations where a person is prone to do those kinds of things, that poor judgment would be seen as a dangerous symptom. And then there are things like auditory hallucinations. So that's like hearing things, and delusions, which are fixed false beliefs. For instance, believing that the CIA is spying on you, or believing that you're king of the world, or those kinds of things. And then anxiety. Those often are not dangerous in and of themselves, but sometimes they can make the dangerous symptoms more likely to occur. So for instance, if a person is hearing voices telling them to harm somebody or telling them to harm themselves, then obviously that's going to, that's a dangerous symptom at that point. If the delusion is, I believe I can fly, and then I decide I'm going to try to go to the top of the building and try to fly, that's obviously very dangerous. And then anxiety itself, like I said, on its own may not be dangerous, but sometimes the anxiety can be so uncomfortable that if the person is already having thoughts about not wanting to live, then it could increase the risk even further. So those are the dangerous symptoms. Let's talk about the specific psychiatric illnesses that sometimes lead to these symptoms. So the first is bipolar disorder. So bipolar disorder is a mood disorder where patients will have mood episodes at different times of their lives. And a mood episode could either consist of mania or depression. So in mania, these individuals will have an increase in mood, feeling cheerful, jubilant, excited, euphoric, in ways that aren't normal for them. And at the same time, they may also have increased energy, and their thoughts are moving much more quickly than normal, and they're talking a lot, and they're engaged in lots of activities, and they're also engaging in risky and impulsive behaviors. So you can see right there with that last symptom, that engaging in risky impulsive behaviors, that can then lead to dangerous outcomes. So these are the individuals who might be more prone to do the dangerous things I mentioned before, trying to scale a building, trying to, or driving 120 miles an hour, these kinds of things that can be, deadly, even if they weren't intended to be that way. And then these individuals can also have the grandiose delusions, feeling like they're king of the world, feeling like they can fly, as I mentioned before, which again can then lead to something dangerous happening. When patients with bipolar disorder aren't manic, they could also be depressed. They can have depressive episodes where they're feeling down and sad, and at the same time, not motivated to do things, and maybe not eating much and not sleeping very well. And sometimes patients experiencing these depressive episodes can also start having thoughts about death and wishing to be dead. And so that's where we see the suicidal ideation creep up. And that's one of the aspects of this illness that makes it so dangerous. Major depression is another mood disorder like bipolar disorder, but unlike bipolar disorder, these individuals never have the manic episodes. They simply have the depressive episodes. So again, the down mood, the sleeping changes, the ideation. Schizophrenia is an example of a psychotic disorder. So it's not a mood disorder, it's a psychotic disorder. And by psychotic, what we mean is the voices, or they may experience the delusions. Those are the fixed false beliefs. And they could be in the form of paranoid thinking. They can be grandiose in nature. And these individuals might also have trouble with just functioning in general, functioning in life. So not being able to hold a job, not being able to maintain relationships. And so this illness can the hallucinations or the delusions that lead to Excuse me, forgive me, I've got some bad allergies right now. But this can lead to the hallucinations that may tell them to hurt themselves or to hurt others, or maybe paranoid delusions that people are spying on them, and so they might think that they need to then take action against those people who are, who they think are spying on them, and that can then lead to violence potentially. But I want to say again, as I said before, these dangerous symptoms are quite rare, and so even though they could be dangerous, I don't want people to walk. And then there's a condition called adjustment disorder, which, just to simplify, it's basically saying that a person has experienced a significant stressor in their life, and they're not necessarily having a psychiatric illness, but they're feeling distressed from that stressor. And sometimes that, excuse me, that too can lead someone to suddenly start having suicidal thoughts, wishes to be dead, because they feel so overwhelmed with whatever it is that just happened to them. Maybe a job loss or relationship loss. So these are all illnesses that are associated with those dangerous symptoms that I mentioned, or I should say sometimes associated with those dangerous symptoms. So let's talk about the sequence of holds that are used during this process of involuntary hospitalization. So there's the 1013, the 1014, and the 1021. So I'll explain what all those mean. And let me also say that this is unique to the state of Georgia. Every state across the country has their own process. So what you're going to hear about now is what happens in Georgia. So the 1013 can be filled out by a physician. And basically, as long as the individual is showing signs of mental illness, so hearing voices, feeling depressed, and they also either pose a threat of harm to themselves, pose a threat of harm to others, or are so unable to care for themselves as to pose an imminent danger to self, as long as those criteria are met, then the 1013 can be filled out by the physician. And what this does is it takes the patient out of the community and into a psychiatric emergency room for an emergent psychiatric evaluation, so that psychiatrists can figure out what's going on and how can we help this person. Excuse me. Now, the 1013 allows the patient to be held in a psychiatric emergency room for up to 48 hours. That allows the psychiatric team, again, to try to figure out what's going on and what would be the next best step for this individual. At the end of 48 hours, the patient can be sent home, or even within the 48 hours, they can potentially be sent home. Or the psychiatrist can decide, you know what, this is pretty serious. Excuse me, I'm just going to take a sip of water. The psychiatrist might decide that this is pretty serious and the patient needs to be hospitalized. That's where the 1014 comes in. So it's the same criteria as I just mentioned. Excuse me. What this does is it takes the patient out of the psychiatric ER into a psychiatric inpatient unit for actual treatment to begin. Now, the patient doesn't have to accept the treatment. They can be in the hospital and refuse the whole time, but at least they're in that hospital setting. And there they can be held up to 5 business days, weekends and holidays excluded. Again, so there's enough time to help the individual and to make sure that they're safe before they get discharged. But sometimes that doesn't happen. In other words, the 1014 reaches its end and the patient still isn't in a condition where they're safe enough to be discharged back home. So the 1021 is another piece of this puzzle, and it requires the same criteria. But what this will do, if it's agreed upon, is it keeps the patient in the hospital involuntarily beyond the duration of that 1014. The duration is determined by a judge who will come into the hospital for a hearing. And then they'll determine if the patient, or how long the patient should stay, and if the patient continues to make progress and needs to continue to be held. So there are checks and balances in place. There is advocacy for the individual. They're given a lawyer who will advocate for them. And Excuse me, this is not a great week for allergies. And the judge will determine this. But again, like I said, checks and balances to protect the individual and their civil rights. Here are 5 different ways a person can be held involuntarily in a psychiatric hospital. And this actually might be important to many of you who have loved ones who are struggling with psychiatric illness and need help and maybe need to be in a hospital, but that loved one is not willing to get it. So here's how this could work. The first is that the physician who's just evaluated the patient can complete the 1013, which then empowers the sheriff to find the patient and take them to the nearest psychiatric ER. So that's what I just described about the 1013. But the issue here is that the loved one has to agree to see the physician in the first place. And maybe they're not agreeing. And that's the trouble, is that they're not seeing someone who can then help them and try to figure out what's going on. Another option is a family can call mobile crisis, which you can do by dialing 988, 3 digits, 988. And they will send a clinician to the home to perform a psychiatric evaluation, and they can then complete a 1013 themselves if it's appropriate. But they may get there and find out that regardless of what you have told them, the patient themselves is not really endorsing anything that would meet criteria for that 1013. Another way that the individual can wind up in the psychiatric ER is if the police arrest that individual for a crime, but then determine that the person is suffering from a psychiatric condition, and then they would bring the person, hopefully I should say, would bring the patient to a psychiatric ER instead of to the jail. A family can go to the probate court downtown and fill out paperwork to convince a judge to complete an order to apprehend. Now, the way that they convince the judge is basically by providing the same information that you would provide, or that the physician would provide on the 1013. Are they having signs of mental illness? Are they posing a threat to themselves, posing a threat to others, that kind of thing. And then if the judge is convinced, then, like I said, they will complete the order to apprehend, which will then send the sheriff out to find the individual and bring them to a psychiatric emergency room. And then 5, family can sometimes seek emergency guardianship. And if they're granted that, then they can use this power to have the loved one hospitalized. So 5 ways to do this. I need to make a plug for the research clinic that I work with at Emory, and just say that if you know someone who is struggling with anxiety or depression, please call 404-778-MOOD. So it's the Emory Mood and Anxiety Disorders Program. We have a number of clinical trials to study different medicines to see if they help. And I will stop here for some questions about involuntary psychiatric hospitalizations, or really anything about psychiatry that I can help with.
Thank you, Dr. Rakofsky. I have a question. You talked a lot about psychiatric illnesses, and we're here in the Alzheimer's Disease Research Center, and there are many impaired persons living by themselves, and they have a lot of behaviors that need to be checked, and maybe they're not belligerent necessarily, but they're certainly unsafe. Do these same things apply to people with advanced dementia, the different levels of hospitalization, orders? I'm going to say the 1013, 1021, for people with dementia. Is there a similar kind of rating?
I assume it's similar. I mean, it's the same idea that if they're having so some folks with dementia may have auditory hallucinations, and then if they're also having suicidal thinking or homicidal ideation, then they would meet that 1013 criteria. The challenge is finding a hospital that might be comfortable treating someone of an older age that had a lot of complicated medical comorbidities, other medical illnesses. That often becomes the challenge. But I'm not aware of another mechanism. I'm pretty sure 1013 is the starting point.
Okay. On that note, in recent news, there was the hospitalization of celebrity Wendy Williams. And I think based on what you described, she probably has some significant psychiatric illnesses. And I think the reason I'm asking the question is a lot of times psychiatric disorders do overlap with dementia pictures. And I'm not sure that we do a really good job of this is dementia or this is some psychotic problem and not necessarily Alzheimer's or some other dementia. And I think that there's a problem in a lot of doctors' minds, but certainly in the public's mind about what the difference is and should we treat them differently.
Yeah, I've seen my patients with severe depression leave a hospital stay with a new diagnosis of dementia because the doctor's working with the patient all profound cognitive problems, and maybe they were able to get some neuropsychological testing, and they decided this patient met criteria for dementia in addition to the severe depression. Only to then discover that once the depression improved, the cognitive problems resolved. And so that dementia diagnosis was inappropriate. So sometimes depression can get so severe that it could affect cognition to the point where you might think the individual has dementia, but they really don't. So we definitely have to be very careful because that could then lead to, and in fact, it did lead to the family becoming upset about the new dementia diagnosis and what does this mean for the loved one and for the family, and it was that was something that didn't have to be. It was an inappropriate diagnosis is the point, and so we do have to be careful about making the right diagnosis and recognizing that some psychiatric illnesses can look like dementia even though it's not dementia. Another example would be schizophrenia. So in schizophrenia, we do see that there are cognitive changes that occur, but it's not the same as dementia. It's just part of the schizophrenia itself. We call them negative symptoms, and so that again could look like schizophrenia. I'm sorry, could look like dementia.
There are some questions in the chat, Dr. Rakofsky. Two of them relate to psychiatric hospitals in the Metro Atlanta area. For cognitive stabilization and insurance coverage. So can you tell us the names of some psychiatric hospitals? Because people say it's an emergency, let's rush them to the hospital. And, previously in geriatrics, I knew that our Wesley Woods had that designation, but it doesn't necessarily anymore.
So the questioner is looking for names of psychiatric hospitals that will accept people with cognitive
psychiatric disorders, like what we're talking about. I think
yeah.
General question.
Yeah, I don't know which local hospitals have geriatric units. I know so Wesley Woods obviously used to have that geriatric psychiatric unit. The hospitals that I work with these days are Emory Decatur. So that's where the Emory Psychiatry inpatient unit has moved to. So we're now at Emory Decatur Hospital. And then outside of that, other hospitals that I've had patients hospitalized that include Ridgeview, Peachford, Summit Ridge, but I can't really speak to the quality or to insurance issues or anything like that. I just know that these are different hospitals that exist locally. So yeah.
Okay. Somebody said Wesley Woods Hospital was the best. It was. I'm just a little biased. Let me see. You said Emory Decatur. When you say Emory Decatur Hospital, are you talking about the long-term hospital or I don't know, there are a couple of them. But they're two mainstream downtown Emory hospitals, and I'm not sure which one you mean.
So Emory Decatur Hospital, the acute hospital, like the med-surg hospital. It used to be, was it DeKalb?
DeKalb Medical, right?
DeKalb Medical. Oh yeah.
Okay, that's the Decatur Hospital you're referring to.
Yes.
Okay, Okay, I'm trying to address some of the questions in the chat about insurance and psychiatric coverage. I'm not sure where you would send somebody who doesn't have insurance coverage for psychiatric disorders. Is there a state health facility?
For psychiatric
Psychiatric
hospitalization?
disorders?
Yeah, so Grady, so usually so Grady obviously is a place where some of our patients go. And then DeKalb Crisis is another place that helps folks who don't have insurance, or that can take patients that don't have insurance. And then I don't know about I'm not sure about any other hospitals that treat the underserved.
Okay, that seems like a pretty good answer for me.
Mhm.
I'm trying to see anything else. Okay, there's a question in the chat about trauma, head trauma and dementia.
Mhm.
The VA, um, does the VA have a psychiatric care unit? And I know that they have PTSD programs, but
Yes, so the VA, the Atlanta VA has a psychiatric emergency room, first of all, which is good to know. And then they also have an acute stabilization unit. So there's that. As far as a long-term kind of thing, I'm not familiar with that.
that is important to know that they have a psychiatric emergency room at the VA.
Yeah,
Of course, you have to be a veteran to access it.
right.
Let's see, what else? Okay, this question is from Marnita Floyd. Does dementia stemming from profound or extensive substance use look different than Alzheimer's or schizophrenia?
So I'm not a dementia expert, so I couldn't say for sure. Um,
A lot of people with substance abuse disorders do experience a lot of hallucinations.
right.
I think that's probably the question.
Yeah, I mean, I would wonder about age of onset. So maybe someone who had dementia that was due to heavy use of, heavy and long-term use of cocaine, might then you might see more strokes, and maybe it might come on sooner than when maybe Alzheimer's might be expected to present. But as far as the different symptom constellation, I'm not sure. I don't know enough about them to be able to say for sure.
But is like a substance abuse related psychosis something that you will recover from?
Oh yeah, yeah, definitely. So substance-induced psychosis. I mean, the nature of all the substance-induced conditions, dementia aside, but things like substance-induced depression, substance-induced mania, substance-induced psychosis, the idea is that once the drug clears from the person's body, those symptoms will resolve. So, if the person is doing cocaine and then they start hearing voices, once they stop cocaine, after a couple of days, those voices should go away.
Okay. All right. Let me see what else. This might fall under the role of social worker or licensed therapist. Are there any risk management steps families might take to reduce the risk of an involuntary hospitalization? Safety plans, securing weapons, or something like that?
Yeah, well, if the person already is connected to a psychiatrist, then the role of the family, with the loved one's permission, would be to reach out to the psychiatrist if they're noticing early signs and symptoms. And that way they can have an early intervention and address whatever symptoms are starting to develop before the symptoms get significant enough that they lead to that involuntary hospitalization. So family involvement, if the patient's already seeing a psychiatrist, can be really crucial to staving off that involuntary hospitalization. If there isn't, a psychiatrist in the picture, I think all the things that were suggested, safety plans, securing weapons, I think that's all smart. That makes sense. But really, the goal is to get that person to a psychiatrist so that they could be evaluated and treated. And if it doesn't happen in the outpatient setting, then I imagine things will get worse, then eventually it then winds up happening in the hospital setting.
So let me see, there's one other question. I'm not sure how much you can see. This is from Mrs. Tepperman. Geriatric psychiatry is an important specialty. How do you find someone who does that?
I agree, it's important. I would say first that we have a geriatric psychiatry division within our Department of Psychiatry here at Emory. You could always call and see if anyone's taking patients. But there also, I believe, is a website for the geriatric. There's an association of geriatric psychiatrists in America, and I can't remember exactly what the name is, but I believe, I imagine on their website they may have ideas of how to find other geriatric psychiatrists across the country. I remember looking at this for a family member many years back. But I can do a quick search. American.
Somebody's looking for that. I think
Okay.
Crystal are probably looking at that, but on
Perfect.
that note, though, when we
Yes.
start talking about psychiatrists for geriatric patients, what's the difference using a geriatric psychiatrist versus a general psychiatrist?
Well, geriatric psychiatrists complete a geriatric psychiatry fellowship. So it's additional training on top of the residency training that we all do to become psychiatrists. And during that specialized training, they focus exclusively on geriatric patients who have different psychiatric illnesses. So they learn nuances and they learn things that are specific to the population and get lots of exposure to that so that they're ready to be specialists in that area. Whereas those of us who just do the general, basic residency, we get a little bit of exposure to that, but not to the same level. So the geriatric psychiatrists are going to be more familiar with, how to dose some of these psychiatric medicines that we normally use for adults. For older patients, they'll know, how to adjust those medicines to avoid some of the problems that can happen when you give medicines to older individuals. They may be more familiar with some of the psychological challenges that patients face when they get to the older ages of life and what some of the family members and loved ones of that patient may be going through. So if one is able to find a geriatric psychiatrist for your geriatric loved one, that's a great way to go. But they may be hard to find. Psychiatrists in general are hard to access, and so if that's the case, an adult psychiatrist would be better than not having a psychiatrist, but certainly a geriatric psychiatrist would be a good option.
And the last questions that I see are related to state hospitals. You mentioned Grady Memorial Hospital and DeKalb Crisis Center for certainly patients that are uninsured in the state, but there is some mention about a psychiatric hospital. I do know that that's what a Ridgeview is, but they're talking about Georgia Mental Health Institute.
Yeah, so that's what's now the Emory Briarcliff campus. GMHI was a true, long-term care state psychiatric hospital. There used to be many of them, and over the years, those were shut down. There's still Georgia Regional Hospital still exists, but places like Ridgeview, all these different hospitals that I mentioned, my understanding is they're really for acute care. There aren't they don't I don't believe they often have long-term facilities for patients to stay for very long. By long, I mean like months, years. Back in the day, that's what happened in psychiatric hospitals. Patients would stay for months or for years. These days, patients stay for days. Unless, as I mentioned, in the 1013, 1014, 1021 scenario, the patient just isn't getting better and still remains dangerous. But anyhow, GMHI used to be one of those facilities, one of those longer term psychiatric hospitalizations. And but eventually I believe they lost funding, and so the GMHI building is now the Emory Briarcliff building, which for a while was being used for movies. and different TV shows as a filming location. Stranger Things was actually filmed at that building.
Really?
Yeah. Hawkins Lab was that building.
Okay, I'm not seeing any other questions either in chat or with Q&A, but thank you so much, Dr. Rakofsky, for your presentation. I learned something. I knew about 1013. I didn't necessarily know about a 1014, but that was a revelation for me. So, one other thing here, most communities from Tasha Lewis, she says community service boards have crisis stabilization units that can hold a client for 3 days and refer as needed. Crisis stabilization units. I'm imagining that's what the CAB crisis unit does and what the Emory Decatur Hospital does, right?
I think crisis stabilization unit is a particular designation. I'm not an expert on this, but because I remember that Grady back in the day had an inpatient psych unit, but they also had a crisis stabilization unit. And so I believe it's a particular designation. Yeah, so, but I think it would serve the same purpose, which is to provide monitoring and safety and treatment to someone when they're in the midst of one of these crises and having these, a particular dangerous symptom.
Okay, thank you again, Dr. Rakofsky, for your presentation. Ms. Bush and Ms. Davis had put in the Georgia crisis line numbers. That's 1-800-715-4225. If you are with someone who's experiencing a mental health emergency, or the 988 suicide and crisis lifeline by calling or texting 988. So DeKalb Crisis Center and the Georgia Crisis Access Line. Again, 1-800-715-4225. And as Dr. Rakofsky explained, most of this is for mental health illness, but a lot of times, as we've learned, sometimes persons with dementia do present with psychiatric syndromes or symptoms. So, okay, Crystal said the DeKalb Crisis Center Central Access number is 404-892-4646. DeKalb Crisis Center 404-892-4646. And these numbers are available for use by anybody with or without insurance, as I understand it. Thank you, Dr. Rakofsky, and thank you everybody who joined us today for today's Brain Talk Live. I do appreciate your time. Thank you.